Last winter, the flu epidemic caused our hospitals to overflow. Normally lengthy ER waiting times became longer. A major reason was long-term care residents caught up in the flu epidemic. It became so bad that Windsor Regional Hospital quietly took down the waiting time tool on their website. They haven't replaced it yet. Presumably, they think no news is good news. This week, the government announced it's opening 20 temporary hospital beds in Windsor to deal with the coming flu season. This is good news, but it's a temporary fix. Behind the story, I see some critical flaws in the proposal for our new hospital system. It doesn't address the realities of our demographics. Windsor Essex is more spread out than it used to be. Because of this, we need more distributed healthcare services rather than concentrating them. Our hospital plan reduces our two remaining hospitals into one that's 4 kilometers beyond Windsor Airport. It adds no satellites to county municipalities. It adds no long-term care capacity for seniors. The $2 billion healthcare investment doesn't create permanent fixes to the root causes of our problems. Siloed thinking is just about the worst way to make expensive decisions. What it's good for is making expensive mistakes. 90% of our long-term population growth will be among those aged 75 and up. 90%. The remaining 10% will come from those aged 65 to 75. The population younger than 65 is not expected to grow. 30,000 of our residents are older than 75 today. This number will almost treble to 80,000 in 25 years. I will be one of them, which is partly why this is so important to me. I realize not all seniors are sick, and not all sick people are seniors, but it is true that people in the last few years of life are by far the highest users of healthcare resources. The average age in the ER during the last flu epidemic was 72. Windsor Essex is aging more rapidly than the GTA, where residents have many hospitals to choose from. Our proposal gives us just one. Humber River Hospital opened 2 years ago with 656 beds. It was built with capacity to expand to 722 beds. Now, 2 mothballed hospitals are being reopened to add 225 temporary beds. If planners miscalculated so badly in Toronto, I wonder what will happen to us in Windsor Essex. Our plan adds no beds on opening day and only 170 more beds after 15 years. We could use those beds today. Our decision makers like to tell us our plan is just perfect. It's a plan that demolishes both of our existing hospitals. We won't have the luxury of a mothballed facility to fall back on if it falls short of perfect, which is actually the more likely outcome. What if the real reason for the hospital problems is that we simply don't have enough acute care capacity? There is disturbingly pervasive messaging that people use the ER for trivial conditions. It's often used to justify replacing our downtown hospital, Olet campus, with urgent care. But to me, it sounds a lot like sick blaming. How is a patient expected to know the seriousness of their condition before they see a doctor? A better idea is to build an urgent care adjacent to the ER, but not as a replacement for existing services. Urgent care alone will be insufficient for the 80,000 residents in Windsor's core and West End. These neighborhoods are home to a greater proportion of older residents and people with disabilities. The percentage of non-drivers is much higher than elsewhere in the region. For those on fixed incomes, cab fares to hospital will be cost prohibitive. Will the frail and the sick be expected to take the bus to hospital? The planners tell us that 80 to 90% of ER patients aren't admitted, but that doesn't mean that their problems have been resolved. Many go home with a referral to see a specialist or to have an operation or visit a clinic. Often patients need multiple appointments. If data on follow-up care for unadmitted patients is tracked, I suspect it would show that the proposed UCC will not be a one-stop shop for the vast majority of patients. What hospital planners don't talk about explicitly is that 1/3 of patients at the Olet campus ER have CTAS 1 or 2 emergencies. Those are levels of acuity that cannot be treated at a UCC. About half of these patients come from the urban core. That's much more relevant than measuring how many don't need to be admitted. There is no public analysis showing the impact of transferring those who do need hospitalization. Administrators like to mention the inconvenience of patient transfers for the 4 kilometers between our existing campuses, and meanwhile the distance between the proposed UCC and the new hospital is 15 kilometers. I'd like to see how much cost and inconvenience is being downloaded onto residents who can least afford it. How can a UCC that closes its doors at 10 p.m., doesn't accept ambulances, and only treats non-life-threatening conditions be an acceptable alternative for patients who currently have access to 2 full-service hospitals? Nobody disputes that our hospital system needs major infrastructure investment to serve our future needs. We need more capacity to deal with a population that's rapidly aging. County residents deserve a share of the healthcare investment too. However, we cannot do this by withdrawing services from Windsor's urban core. Increasingly, I believe we need to reconsider the advisability of one mega facility to serve the regional population. I would welcome a public discussion on 2 hospitals, one in the core and another closer to the county. There is a role for urgent care centers, though my preference would be to build them adjacent to hospitals, as well as in some of our smaller outlying communities. I frequently hear from residents who believe the decision-making around the new hospital is political rather than fact-based, and that's why I'd like to address the optics of the politics. Last weekend, an older lady approached me and asked if I was the person spearheading the opposition to the mega hospital plan. She had recognized me from the media and said she's very worried. She said it's a pity that it's all so political. Unfortunately, she's not alone in holding that opinion. 2 large stakeholder groups are excluded from the public engagement process, and this seriously undermines its integrity. One group are the inner city residents who stand to lose the most under the proposal. Very little effort was made to invite them to public meetings. Few meetings were held in their neighborhoods. We regularly meet people who don't know that the 2 existing hospitals are to be demolished under the plan. Another substantial stakeholder group are muzzled. They are the healthcare professionals, doctors and nurses who work at the hospitals. City workers and people who work for nonprofits receiving funding from the city fall into this group as well. I like to be proactive, so I want to bring all of this to our LHIN's attention. The LHIN's mandate is to manage the planning, integration, performance, and funding of the healthcare system. Community engagement is a legislative responsibility. They claim it's a core function. But if you thought it'd be easy, you'd be mistaken. Communicating with our LHIN is very challenging. The Erie-St. Clair LHIN consists of 6 subregions spanning 3 counties. It's a Crown corporation with 9 board members. Their office is in Chatham. That's an hour's drive from here, and it's where they usually hold their board meetings. Windsor, with a third of the LHIN's regional population, has no board members. 0. A fifth of the population lives in the subregion that consists of Tecumseh, Lakeshore, Amherstburg, and LaSalle. While they have 2 board members, this area has no hospital infrastructure and none planned under the proposal. That leaves 4 subregions. Collectively, they have less than half of the total population, and yet they have 7 of the 9 board members, including the chair of the board. Windsor has none. There are clearly some serious barriers to communication between Windsor residents and our LHIN. Though we have a third of the population, we have no board representation, and residents cannot easily attend a meeting to express their concerns. I tried calling and writing to try to arrange a meeting with the LHIN. I'm sad to say that in over 3 months of effort, I've been completely unsuccessful. Without clear communication channels, the integrity of the entire process is compromised. If we can't communicate with the organization charged with overseeing our healthcare planning, then I see this as a critical failure. It needs to be addressed before proceeding further with the planning of our new hospital system.